Welcome to the deep dive. Our mission, as always, is to cut through the noise and really get to the core of critical information.
Exactly.
And today we're doing a deep dive into disease outbreaks and, well, public health generally.
It's a big one.
It is. We've gathered your sources to really unpack the definitions, the characteristics, prevention strategies for these major health events.
From epidemics to pandemics.
Right. And we'll focus specifically on COVID-19 and measles as sort of key examples.
Yes, see how these ideas work in the real world.
So our goal for you, the listener, is really to get past just the what happened.
Right, and give you a clear understanding of the why it matters. These topics are complex.
They are.
We want you to, grasp the nuances quickly, maybe have those aha moments.
See the connections.
Exactly. See the interconnectedness of it all, how a disease unfolds, spreads, and crucially, how we try to manage it.
Okay, so let's start with the basics, the language itself. Epidemic, endemic, pandemic. Let's unpack those.
Good place to start.
First up, epidemic. What exactly defines that?
Okay, so an epidemic is when you see a disease pop up in a community or a region at a frequency that's clearly more than you'd normally expect.
So an unusual jump in cases?
Precisely, a significant jump. Normal expectancy is often based on, say, the average cases over the last 3 to 5 years.
Okay.
But here's an interesting point from the sources. If the normal number of cases is 0.
Like a disease not usually found there?
Exactly. Then even one single case counts as an epidemic.
Wow. Okay, like the yellow fever example in India you mentioned.
That's the one. One case would trigger an epidemic declaration because it's just not normally there.
And people often say outbreak, right? Is that the same thing?
Yeah, often used interchangeably, like a food poisoning outbreak. Lots of people sick quickly, maybe from the same meal. That's essentially a type of epidemic.
Got it. So that's epidemic, surge beyond normal. What about endemic?
Right. Endemic is different. It's when a disease is just consistently present in a population or area.
Always there.
Pretty much, yeah. At its expected sort of baseline level. Not necessarily causing a huge crisis, but it's around.
Like diphtheria in India or leprosy.
Exactly. Lymphatic filariasis is too endemic in hundreds of districts there, affecting millions. It's about a stable, predictable presence.
Okay, so epidemic is a spike. Endemic is a constant presence. What about pandemic?
Well, that's when things really scale up. A pandemic is basically an epidemic that goes big.
How big?
Affecting a large chunk of the population across a really wide area. Could be a whole country, a continent, or, the whole world.
And it spreads country to country.
That's the key characteristic, yeah. Country to country spread.
Like COVID-19.
The prime example. The WHO declared it a pandemic on March 11th, 2020.
I remember that day.
We all do. And historically, it's interesting, only certain influenza A strains caused pandemics in the 20th century.
Right, Spanish flu, Asian flu, Hong Kong flu.
Each from a new strain. And HIV is, of course, often described as a modern pandemic.
Okay, that vocabulary is really helpful. Epidemic, endemic, pandemic. Now let's apply this to, well, the one we all lived through, COVID-19.
Right. Let's get into it.
So the cause was SARS-CoV-2, a new beta coronavirus first seen in Wuhan, China, late 2019.
A single-stranded RNA virus.
And its characteristics were important, weren't they? Like its sensitivity to disinfectants.
Definitely. Vulnerable to UV rays, alcohol-based sanitizers, chlorine, that was key early on.
But not cold temperatures, it could resist those.
Yeah, it resisted cold, but heat could decrease its replication. Those properties shaped a lot of the early advice.
And the scale was just immense. Globally, by late 2022, what was it, over 600 million cases?
And over 6.5 million deaths worldwide. A staggering toll.
India saw its first case early, Jan 2020, but its rates per million were relatively low.
Comparatively, yes.
Yeah.
Among the lowest globally, which is quite remarkable given the population size.
What really defined the fight against it, though, was the constant change, right? The variants.
Absolutely. Constant mutation, new variants popping up, potentially changing how easily it spread, how sick it made people.
Or even how well vaccines worked.
Exactly. It was a moving target the whole time.
Yeah.
Made public health responses incredibly challenging.
Which brings us to the clinical side. How did we even identify a suspect case initially?
Well, typically, it involved acute respiratory symptoms, fever, cough, especially with recent travel to an affected area, or contact with a confirmed case.
But the symptoms themselves were so varied, weren't they?
Hugely varied. That was a major feature, from something like a mild cold all the way to, critical multi-organ failure.
Common ones were fever, cough, fatigue.
Yeah, and that unique loss of smell or taste some people got, anosmia or ageusia.
Sometimes even before the breathing problems started.
Right. But it could also look like other things, which made diagnosis tricky.
Especially in older people.
Yeah.
Or immunocompromised.
Yeah, sometimes they'd just show fatigue, confusion, maybe diarrhea, loss of appetite, sometimes no fever at all.
So not always the classic picture. And the risk factors for getting really sick.
Age was a big one, especially over 60. And underlying conditions, diabetes, heart problems, lung disease, cancer.
Immunosuppression, smoking too.
Those two, yeah. They all increase the risk of severe disease significantly.
And the severity itself had grades, right? Mild, moderate.
Severe and critical. Mild was symptomatic, but no pneumonia. Moderate had signs of pneumonia, but oxygen levels okay.
Severe was when oxygen dropped or you saw signs of like acute respiratory distress syndrome.
Exactly. ARDS, septic shock, multi-organ problems. Critical was really life-threatening ARDS territory.
And the complications went beyond the lungs too. Things like blood clots.
Yes, pulmonary embolisms, strokes, acute coronary syndrome, even delirium.
And that black fungus mucormycosis, particularly in India.
Yeah, a devastating fungal infection linked to thousands of COVID cases there. Really sobering.
It really underscores why control and prevention were just so vital. How did India structure its healthcare response?
They used a three-tier system, which was quite effective. COVID care centers for mild or pre-symptomatic cases needing isolation.
Okay.
Then dedicated COVID health centers, or DCHCs, for moderate cases needing oxygen support.
And for the most serious.
Dedicated COVID hospitals, DCHs, with full ICU capabilities for severe and critical patients.
Isolation was key too, wasn't it? Breaking the chain of transmission.
Absolutely central. Isolating suspected and confirmed cases, often at home for milder cases if possible, with careful monitoring.
And we all remember the slogan, Dagaj ki duri, mask hai jaruri.
A distance of 2 yards, a mask is essential. Really captured the core behavioral advice.
Masks, physical distance, hand hygiene, avoiding touching your face.
Covering coughs, sneezes, getting tested promptly, isolating.
All part of that COVID-appropriate behavior.
And treatment. Beyond basic symptom relief.
For mild cases, paracetamol fluids. For more severe cases, it was about supplemental oxygen, careful fluid management, organ support.
What about antivirals like remdesivir, used for certain hospitalized adults? Yeah. Also, tocilizumab sometimes. But generally not recommended for kids due to lack of data back then. Antimicrobials were also used if bacterial co-infections were suspected.
And then vaccines. The speed of development was incredible.
Truly remarkable. By 2022, India had authorized, 6 different vaccines for emergency use?
Covishield, Covaxin, Sputnik V, others too.
Janssen, Pfizer, Moderna, a real portfolio.
And the rollout was phased, wasn't it? Starting with healthcare workers.
Right. Healthcare and frontline workers first, then older age groups, starting with over 60s and those 50-60 with comorbidities.
Then eventually everyone over 18.
And then teenagers, 15-18, using Covaxin initially. A massive logistical undertaking.
Side effects were mostly mild, right? Sore arm, fatigue.
Yeah, the common ones were injection site pain, redness, swelling, maybe fatigue, headache, muscle aches, sometimes fever, usually short-lived.
Severe reactions were very rare.
Very rare, yes. Things like difficulty breathing or a severe allergic reaction.
And underpinning all this was surveillance, testing, contact tracing.
Crucial. Strengthening labs, boosting the public health workforce to find cases and trace contacts quickly, mandatory reporting. All vital to track and control the spread.
That overview of COVID really drives home the scale of a new pandemic. But your sources also bring up an older threat, measles.
Yeah, and it's a really important counterpoint.
It makes you realize public health isn't just about new viruses, is it?
Not at all. Measles is a stark reminder that diseases we have vaccines for can still be incredibly dangerous if we drop our guard.
So what makes measles stand out? If you had to pick one key diagnostic feature?
For me, it's got to be Koplik spots.
Tell us about those.
They're tiny, bluish-white spots on a red base inside the cheek, usually opposite the lower molars.
And they appear before the main rash.
Yes, about a day or two before. They're considered pathognomonic, meaning if you see them, it's pretty much definitely measles. Catching those early is huge.
So the spots come first, then the rash.
Exactly. The typical maculopapular rash usually starts on day 3 of the fever, often on the face, and spreads downwards and outwards. Centrifugal spread.
And other signs. Red eyes, cough.
Yep. Conjunctivitis red, watery eyes, often sensitive to light. And a high fever is characteristic, plus that classic trio Cs. Cough, coryza, runny nose, and conjunctivitis.
And malnutrition makes it worse.
Significantly worse. Malnourished children are at much higher risk of severe measles and its complications.
It sounds quite distinctive once you know what to look for. But what happens if a child gets it? What are the serious risks beyond the rash and fever?
That's where measles gets really scary.
Yeah.
Morbidity and mortality are high, especially in developing nations or among malnourished kids.
How high?
The mortality rate can be up to 400 times higher for malnourished children. It's devastating.
Wow.
Complications include worsening malnutrition itself, severe diarrhea, and serious eye problems due to acute vitamin A deficiencies or ophthalmia.
That can lead to blindness.
It can, through corneal scarring, if not treated promptly with vitamin A.
What about ear infections? Pneumonia.
Otitis media ear infections are very common, especially in young children. Pneumonia is also common and a major cause of death from measles.
And the neurological risks. You mentioned SSPE.
Subacute sclerosing panencephalitis. Thankfully rare, about 7 cases per million, but it's absolutely devastating.
When does that happen?
Usually years later, maybe 7 to 10 years after the initial measles infection, it causes progressive, fatal brain damage.
That's terrifying. Really shows it's not just a simple childhood illness.
Not at all. It has hidden long-term dangers. Diarrhea is also a frequent complication, adding to the risks.
So, faced with such a potentially dangerous disease, what's our best defense? How do we protect communities?
Vaccination, hands down. The measles vaccine is safe, it's highly effective, and it's relatively inexpensive.
What kind of vaccine is it?
It's a live attenuated vaccine, uses a weakened form of the virus, becomes freeze-dried, needs to be reconstituted.
And it's an injection.
Yes, 0.5 milliliter, given subcutaneously, under the skin, often in the thigh for infants or the upper arm.
What's the usual schedule?
Routine first dose is typically at 9 months, though it can be given earlier, after 6 months, during outbreaks, or for malnourished children.
And a second dose.
Recommended between 16 and 24 months for broader, more robust protection. There should be at least 4 weeks between doses.
Can kids catch up if they miss it?
Absolutely. Catch-up is possible anytime between 6 months and 14 years, which is great.
How effective is it?
1 dose protects about 85% of infants. The second dose pushes that much higher. Immunity is generally solid and lasts a very long time, often lifelong.
Are there people who shouldn't get it?
Yes. Contraindications include a severe allergic reaction to a previous dose or components, pregnant women, and children who are seriously ill with weakened immune systems.
And herd immunity is key here too, right?
Absolutely critical. To really eliminate measles, you need population immunity levels over 96%. The threshold is estimated between 83 and 94%. High coverage is essential.
Surveillance, like with COVID, is important for measles too.
Definitely. For spotting outbreaks early and responding quickly.
Now, you mentioned the MR vaccine, measles rubella. That's replaced the measles-only one in India's schedule.
That's right. It protects against both measles and rubella, which is a big advantage.
So the schedule for MR is similar.
Yes. First dose, 9-12 months. Second dose, 16-24 months. Minimum 4 weeks apart. It's often given as the MMR measles, mumps, rubella vaccine.
Same dose and route?
Yep. 0.5 milliliter, subcutaneously, usually right upper arm for consistency in surveys.
And catch-up is possible for MR too.
Yes, same window, up to 14 years. And importantly, it can be given at the same time as other routine vaccines for kids who are behind schedule.
Okay, let's bring it back to that hypothetical 12-month-old child. If we connect this to the bigger picture, what's the real risk if that child misses their MR vaccine? For them and for everyone else?
Well, for the child themselves, the risk is significant. They remain wide open to getting measles, which, as we've said, can be severe, even fatal, especially if they're malnourished. Complications like pneumonia, diarrhea, or that awful SSPE later on are real possibilities.
And the rubella part.
They also remain susceptible to rubella, German measles. Now, rubella is often mild in kids.
But
if that child is female and she contracts rubella years later during early pregnancy...
the risk to the fetus.
Exactly. Congenital rubella syndrome. It can cause devastating birth defects, deafness, blindness, heart problems, even fetal death. So childhood vaccination protects their future reproductive health too.
That's a powerful point. And the risk to the community.
Every unvaccinated child adds to the pool of susceptible people. This lowers herd immunity.
Makes outbreaks more likely.
Much more likely. For both measles and rubella, individual choices really do have a massive community impact when it comes to vaccination. It's a chain reaction waiting to happen.
So we've covered a lot of ground, from those fundamental definitions, epidemic, endemic, pandemic, through the complexities of COVID-19, and then digging into measles and the vital role of vaccination.
Yeah, quite a journey.
Hopefully you, the listener, now have a much clearer, sort of layered understanding of these public health challenges, from the virus itself to the global strategies.
How it plays out individually and across populations.
Exactly. Being well informed on these layers is crucial.
It really is. And maybe a final thought to leave you with. Think about how diseases constantly evolve.
Like the COVID variants.
Right. Combine that with how connected our world is now.
Yeah.
It means public health knowledge isn't just for us experts anymore.
It's essential for everyone.
I think so. It's
Yeah.
a vital tool for every informed citizen. So the question becomes, what new challenges, what new opportunities for understanding will emerge as we navigate a world where a local outbreak can and does become a global concern almost overnight?